Hmm. From a philosophical standpoint, can you talk about the appropriateness for our profession, physical therapists, penetrating the skin? You have no issue with it, I guess.
Are we doing so we don't do sharp debridement anymore where we're cutting off skin? I mean, really, I mean,
But
so
you've
the
seen that
needle,
there are some of those out there that would have concerns that would say, look, this is not our place to be doing that.
well, because they haven't done it and they haven't been educated in it and they don't understand what you're trying to do. It's probably the same people that say trigger points don't exist.
Mm.
Right? Oh, there's no such thing as a trigger point. Okay, then read the hundreds of articles that are out there, or pick up the Travell and Simon's new edition and see how evidence based it is.
Mm-hmm.
Right? So sometimes you just got to take back. I'll give you an example. One of the students came to me and said, I was on a clinical and the clinician was using these points and they were pressing on these points and doing. He goes, I'm not really sure what it was called, but there was different points in the body. And I said, oh, you mean Jones strain counter strain points? He goes, yeah, that was it. I said, I don't do that. I said, but I know it's effective and I know clinicians who do it and they're very effective with their outcomes for patients. I said, but there was so much for me to learn. I just decided that was not a path I wanted to take.
Mm-hmm.
So why not just embrace it and say it's something that I don't do it, but I've heard of great success and I've seen the great success.
Mm-hmm.
Right? So why would I throw anybody? It's like kind of like the different needling approaches. I don't do the multiple needle insertions with E-stim. I have not been educated. I don't do it. I don't want to do it. I do trigger point dry needling. That's my specialty. That's been my focus. Muscle pain and dysfunction. That's the lane I'm in. But I don't poo-poo that somebody's out here. I just say, just be careful that you're not talking about Eastern medicine philosophy when you're teaching this. Right? Because that is the rub. We have professionals, we have to respect the acupuncturist as we want them to respect us for doing dry needling of trigger points or whatever we're doing. You just got to have a mutual respect for other professions and other approaches. Mm-hmm. Right? And I just think it's a problem for us.
Mm-hmm. Mm-hmm. Those who are trained to dry needle are in a minority. If you look at the total number.
Oh yeah, absolutely.
Yeah,
absolutely.
Why do you think that more aren't embracing it, for you to use your words, and being educated and feeling like, yes, this is the direction that I need to go?
Well, when I was in Georgia, I mean, a lot of therapists did needling, a lot, because it's been in our Practice Act since 2004. Mm-hmm. So dry needling has been around in Georgia a long time, and it's in a lot of the entry-level programs. A good chunk of dry needling is within the programs, and so I think it depends on the state, what the practice restrictions are. So, for example, Florida just got dry needling in 2020. You have to have 2 years of experience to do dry needling. Why? I don't know. I mean, your anatomy is never more fresh than you graduate from school, right? So you're sticking a needle into anatomy and knowing your anatomy. So I just think it depends on the state and the battles and where people are coming from and why they would need to do it. So if you're successful in your practice using mechanical therapy or the McKenzie approach, and you're successful in it, sometimes you just say, I'm doing good with this. And if I have a patient that needs it, I'm going to refer them out. Mm-hmm. I'm going to refer them to somebody that does it. I don't want to pay the $3,000 or $1,800, whatever it costs for me to be certified or get additional training for this when I can refer to Jason. Mm-hmm. I'm just going to refer over to Jason. Mm-hmm. Right. So I think it's multifactorial why people aren't. There's a lot of naysayers, but there's a lot of people that are in it and they just go about their business and they integrate it into their practice. And, are you a needler? No, I'm a physical therapist who happens to do dry needling if it's needed, but I'm not a needler. I might needle you a little bit, but it's not a needler, right? I mean, it's just, all you do is McKenzie. That's all you do. No, I doubt it. Right. I mean, Ron Shank, he's a great practitioner, a good friend, right? He's one of the strongest mechanical therapy, but he does other things. He does in addition to that, but that's his go-to, that's his expertise, his knowledge, expertise, and skills are there. But I'm sure he can pivot and shift to something else he needs to do when he needs it. And if he can't, he refers them. Mm-hmm. So I think, this is my soapbox about what we've done as a profession. We think that every therapist should be able to treat any patient that comes through the front door, and we use their 20 visits and, oh, sorry, couldn't help you. But we don't recognize each other as specialists.
Mm.
Go see Joe. He's an OCS, and he's, been doing myofascial pain and dysfunction for over 20 years, and he's very skilled in this. I'm going to refer you over there. No, let's use your 20 visits. Oh, sorry, I can't help you. And then they're paying me cash.
Not a good thing.
Not a good thing. I mean, physicians do that all the time. You come in, I think you need to see an orthopedic surgeon. I think you need to see. Why aren't we saying you need to see this orthopedic specialist, but you need to see this guy because he's an orthopedic specialist and he's got these credentials? We just aren't there yet. I think until we arrive and recognize each other, we're going to have these internet bashing that goes on. And it's not good for the public. The public sees it.
Yes.
The public sees it.
Yes. Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.